The lighting is so bad. Okay, just give me 1 second. Can you guys see me all right now? I'm gonna assume that's a yes. Please feel free to tell me anything in the chat. All right, guys, I'm very sorry for my voice in advance, and I'm very sorry if you hear a very loud cough. I have tracheitis, and I will be coughing occasionally. Good thing is it's not contagious through Zoom, so it's okay. Um, Today we're going to be discussing the ovarian cycle. I'm going to share my screen. I will be using Dr. Abdul Jabbar's, PowerPoint. However, I changed up the order to make it a bit more understandable, in my opinion, and how I feel I can best explain it to you guys. So if you guys find anything difficult, if you find anything specific that you want to go over, that you don't understand that I'm saying, please feel free to stop me, ask me a question anytime, and we'll go over it, okay? And please don't feel shy. You can unmute yourself. If you want to ask in the chat, you can do that. But I can't guarantee that I'm going to see the chat during my presentation, okay? Like, I don't even know where to go right now. I'm really bad with technology. Okay, found it. Okay. Sorry, guys. All right. So, the ovarian cycle. You guys know about the general menstrual cycle. Once a month, the female will shed her endometrium for around 5 to 7 days. On average, 5, but it does differ in between everyone. However, before that, what's happening is that the egg that is going to be released through ovulation and then not fertilized and then resulting in like a menstrual period, we're going to be learning about that. We're going to be discussing what is happening, how the egg is forming, and how it's maturing, and then what happens right before it's released, what happens while it's released, and what happens after to the remnants in the ovary once the egg is gone. Okay? So the things we're going to be discussing, let me put this in presentation mode. There you go. Things we're going to be discussing are hormones, how they relate to the general cycle of egg maturation, follicular maturation, folliculogenesis, ovulation, and then post-ovulation, okay? So gonadotropin regulation, synthesis and secretion of the ovarian hormones, the relationship between the granulosa and theca cells, so basically FSH and LH, and we're going to talk about that. Folliculogenesis from primordial to preantral follicle, and then we're going to talk about how gonadotropin, which is our main hormone in all of this, is kind of controlling the entire thing, okay? Now, there's a lot of words in here already, and it's just the learning outcomes, but we'll make it easy. Now, what I did was I'm going to talk about the hormones more towards the end, because if you understand generally what is happening, then when I talk about the hormones, I feel like you guys will understand it a little bit better to see where it comes in and what exactly it's doing, okay? So this is something I added into the presentation myself. I want you guys to take a look at this really quickly and then see what's happening. So everything starts in your hypothalamus. It's incredibly important. It releases gonadotropin releasing hormone. These are your gonadotropes, LH and FSH, right? So this GnRH, gonadotropin releasing hormone, is a hormone that goes from your hypothalamus down the stalk to your pituitary, and it's telling your pituitary, hey, take out this luteinizing hormone and this FSH, follicular stimulating hormone, and go to the ovary and do something. That's basically what it's saying. This is incredibly important. This is basically what is happening when you hit puberty. You're releasing GnRH from your hypothalamus in pulses like this. Okay? And what's happening is basically your body is getting ready to start, if you're a female, ovulating. So maturing your follicles, ovulating, it getting fertilized, pregnancy, etc., blah, blah, blah. I mean, it's like the main purpose. And then in men, it's first spermatogenesis to start that process formally. Okay? So FSH and LH will go to your ovaries and then they will act on specific cells. We're going to talk about that. And then they're going to result in follicular maturation. What's that sound? Guys, can you please mute your mic? Thanks. All right. And then in the ovaries, then that will result in estrogen and progesterone production. Okay? And those have their own functions, and we'll talk about that too. But first, we're going to go into generally like what's happening in the ovary. So if you understand this, GnRH goes to the pituitary, which results in LH and LH. Then going to the ovaries. Now we're going to talk about what's happening in the ovaries in terms of folliculogenesis, and then we're going to go into the hormone functions, okay? So here's an ovary, as if you cut it in half down the middle. And what's happening is you have your primordial follicles here. We're going to talk about each of these in order, okay? So we're going to start with primordial. We're going to move on to primary, secondary, dominant Graafian follicle, and then ovulation, and then talk about what is happening post-ovulation over here, okay? So this is all the cortex of the ovary, the outside, and then this is the medulla, okay, where the blood vessels come in and basically supply all the nutrients to your ovary. The primordial follicles are basically what you have over there from literally before you're born. So everything in gestation that is being developed in your ovary. These are all your little like tiny eggs that have not yet matured, have not yet entered meiosis or mitosis. And we're going to talk about that. Just give me 1 second, guys. Okay. Okay, so we talked about gonadotropin regulation of ovarian function. We're going to talk about it very quickly again. So GnRH it's released from the hypothalamus in a pulsatile fashion. Guys, this word is really, really important, pulsatile. Can anybody tell me why?
It allows the cyclic secretion of the
Good.
gonadotropin.
Very good. So basically, GnRH, like Maha mentioned, allows for a cyclical, like a cyclical function and release of FSH and LH from the pituitary. So therefore, it's released in pulses like this, instead of normally like just being released all the time like this. Now, the reason is, and you're going to learn this in third year, I'm not going to go into detail about it, is because when it's released in a pulsatile fashion, that is actually allowing the pituitary to not get used to it. So it keeps on releasing FSH and LH every time it receives GnRH, okay? If it were happening in a continuous function, like in a continuous fashion, what happens is the receptors on your pituitary gland start to downregulate because you're always seeing GnRH. They're like, okay, it's always here. That means it's like overboard, and it will stop releasing FSH and LH in response. That's why it's a pulsatile fashion. That's really important. It's naturally like that. You guys will learn more about that in third year when you learn about like, you know, GnRH agonists, antagonists, etc. You don't need to know that right now. It's just a fun fact. It's regulated by dopamine, serotonin, endorphin, norepinephrine. This is a small detail. This is not going to be what you guys are tested on right now, but it is generally important when you guys were learning your endocrinology part. If you guys understand generally like the pituitary physiology and how things from the hypothalamus move down to the pituitary and the things that inhibit it and basically continue in action, then you're good to go. But this is all you need. You don't need to know this in terms of the ovarian cycle. Dr. Abdul Jabbar likes to add this in. FSH and LH will bind to G protein coupled receptors in the ovary. So everything in the ovary is cyclic AMP mediated, okay? CAMP right here. CAMP mediated. Steroidogenesis is CAMP mediated in the ovaries, okay? So estradiol, estrogen, basically, progesterone, androstenedione, these are all steroid hormones, okay? So pulsatile release, cyclic ovarian response, meaning that once a month it's going to do something, right? Once a month it's going to do the ovulation thing, but then over time, folliculogenesis is allowed to happen, and that is irrespective of your menstrual cycles, okay? Now, you have your follicular phase and your luteal phase. Everything I mentioned so far is concerning the follicular phase. What's important about this is the follicular phase can vary from female to female, but the luteal phase is always the same when it comes to your menstrual cycle. It's always going to be 14 days. So 14 days from ovulation, you will have your menstrual period, okay? Before that is the follicular phase, and this is what changes from female to female. The follicular phase is where your follicles are basically maturing, and then eventually the dominant follicle will take over and it will rupture and it will release its oocytes that will enter your fallopian tube, right? Your luteal phase is basically everything that's happening in the ovary after that. So basically the formation of the corpus luteum and then how it results in progesterone secretion and everything. And I'm going to talk about that, but that's basically what you need to, sorry. That's basically what you need to know about that, okay? Okay, so folliculogenesis. This is probably the heaviest, this is like the main chunk of the lecture. It's like the heaviest part. It's okay. If you guys are confused about anything, please just ask, okay? But basically, it's divided into different stages. You first have your primordial follicle, which is there from before birth, before puberty. It's not doing anything. It's just sitting there, right? They're sitting in your ovaries. They're not ready to be used yet because GnRH has not yet basically been released. Now, once you hit puberty, meaning GnRH is slowly releasing in a pulsatile fashion from your hypothalamus, your follicles will start to mature and they'll start to grow into preantral follicles. Then those will start to grow into antral follicles. Then one of them is going to become a dominant follicle, and that means it has the most FSH receptors. That's basically what determines its dominance, okay? And then that dominant follicle is going to rupture and it's going to release an oocyte. And then whatever is left in the ovary, once the oocyte has left, is going to become the corpus luteum, okay? And then everything will go through atresia, meaning it will no longer develop. Atresia basically means failure to develop. The rest of the follicles that do not become the dominant follicles either stay there or they become atretic, meaning that they fail to develop, okay? So your primordial follicle, let's just quickly talk about this. It's what you've had from mid-gestation. You have a lot of oogonia, basically all your eggs, they enter meiosis and become primary oocytes, okay? So they stop in prophase 1. Then, sorry. They'll basically sit there until you enter menarche, basically puberty and in your first period, and then they're reduced to 300,000. So not all of them will undergo maturation, okay? And then when you ovulate, you're going to have about 450 times that you will ovulate in between menarche and menopause. So from the first menstrual period to the very last menstrual period. This is all you need to know about this. They're not really going to ask you about primordial follicles. If they do, in my opinion, it's a waste of a question. So don't focus on this for this lecture, okay? But you just need to know they were there. A lot of them go through atresia, meaning they never develop further. And the rest of them will go to growth and an ovulation when you actually hit puberty and start to menstruate, okay? Now the growing preantral follicle. So let's go back a little bit over here. This is your preantral follicle, okay? Your preantral follicle is basically when there's a formation of a fluid-filled cavity known as the antrum, okay? This is there because this is the first sign of follicular growth, number 1. And you're going to see cuboidal granulosa cells, okay? Once you see the cuboidal granulosa cells, that's how you know, okay, this is a preantral primary follicle. That's it. It's a primary follicle. Cuboidal granulosa cells. That's like, for sure, primary follicle. Now, as they divide and now they become multi-layered, that's when you're going to make your secondary follicle. So let's quickly go back here. So 1 layer, multiple layers. Do you guys see that difference? And you could see the antrum growing again and again until it becomes large in the dominant follicle. That's basically what's happening. And the antrum allows for growth. It carries nutrients and everything. So that's why the antrum is growing, okay? It takes around 3 months for the preantral follicle to form and move from the cortex to the medulla. So again, cortex, medulla. So it's moving closer to the blood supply. And can anyone tell me why? Like why that's important?
Because it'll be the dominant form that gets more blood supply and has more FSH receptors.
Can you say that again? Sorry, I didn't hear you.
The follicle with the most blood supply and the most amount of FSH receptors is the one that will become dominant, and then like become basically the ovum?
Sure. So the reason it moves closest to the blood supply is because it becomes more rich in nutrients right near the blood supply. So the more it's growing, the faster it's growing, it requires more nutrients. That's the reason. But you're right. The dominant follicle is the one with the most FSH receptors. That's the one that's going to move closest and it's going to grow the most. So the oocyte then secretes glycoproteins that form the zona pellucida. Now, why this is important is because this has gap junction, so that allows for different nutrients to enter and exit. And also the granulosa cells express the FSH receptors, okay? Now, these FSH receptors are obviously responding to FSH that is coming from the pituitary. Now, what that does is it allows for production of androstenedione, and then into estrogen, okay? And then the fecal cells have LH receptors, okay? Now, LH receptors will respond to LH, and then this will produce androstenedione, instead of testosterone, but those will be more focused on then producing other androgenic components of the ovary, okay? So you have your androgens and you have estrogen. So FSH is more responsible for the estrogen production in your ovaries, okay? Now, in your growing antral follicle, this takes around 25 days for mature preantral follicles to develop into an antral follicle. So what that means is one of these is not happening every single cycle. They're arresting in different stages in folliculogenesis. So you're going to have some that are primordial or primary follicles, some secondary follicles, etc. And then some of these take 25 days. For example, the antral follicle, I think the dominant follicle, the larger antral follicle takes around 45 days until it's called in and then becomes a dominant follicle, and then it ruptures to release its oocyte, right? So they take different times and different stages take different amounts of time. I'll show you a diagram towards the end of the lecture that shows that, okay? But you have your granulosa cells again, and then you have a basal membrane that separates the granulosa cells from the theca cells, okay? Now, you have the cumulus cells that surround the oocyte, and this is called the cumulus oophrus or the corona radiata. Corona radiata because it looks like they're radiating from the oocyte itself, okay? Now, these are released with the oocyte at ovulation. So whatever is around here is going to leave with the oocyte over here. Do you guys see that? Then the rest of this is going to become the corpus luteum, which is going to produce your progesterone, okay? Now, these follicles are highly dependent on FSH for their growth. So that is why, again, it is incredibly important. GnRH is being released in a pulsatile fashion, going to the pituitary and telling the pituitary, hey, release FSH and LH, more specifically FSH. All the estrogen that is being produced over here in this time, again, it is more FSH dependent. All the estrogen that is being released is inhibiting LH secretion in the first 10 days. After 10 days, when there is even more estrogen, it is no longer negative feedback. Then it becomes positive feedback, okay? So what that means is then it starts to release FSH more. It starts to release LH more, okay? So let's repeat that for clarity. Just give me 1 second. I noticed some people asked some questions in the chat. Just give me 2 seconds and I'll answer them, okay? So GnRH pulsatile fashion goes to the pituitary. Pituitary releases FSH and LH. FSH is obviously binding to the FSH receptors that are on the follicles. They're already there, okay? And then there's going to be more. So the FSH is able to do its job more and more. The follicles that are forming are producing estrogen. That estrogen is slowly increasing. In the first 10 days, that estrogen is telling the pituitary, stop releasing so much LH. It's okay, we don't need any. Then, after 10 days, when there is more estrogen, it goes again to the pituitary. So it keeps going, but after a certain concentration, so typically after 10 days, when it's at a higher concentration, the estrogen, it's going to the pituitary and it's saying, release more LH now. Now we're ready, because now they're going to be entering the ovulation phase. And I'll show you that in a second, okay? Once we talk about the dominant follicle. So during the antral stage, it says over here, the oocyte synthesizes cyclin D1 and cyclin B. This is basically just important for the cell cycle and arrest and where it stops. That's all you need to know, okay? So cyclin B, CDK1 complex. That's all you need to know. Cyclic GMP from the cumulus granulosa cells inhibit oocyte phosphodiesterase. So that basically means it keeps CAMP elevated. And again, what is a CAMP mediated process? Estrogen production, right? Any steroid hormones, estrogen production, that's a CAMP mediated process. So CAMP stays elevated. So again, you're producing more estrogen in the cycle, okay? Granulosa cells start to release inhibin B during the early follicular phase, and that starts to inhibit FSH release from the pituitary because they're like, okay, now that's enough. We have enough now. We have enough follicles. We're going to now focus on the main follicle, okay? That comes to now brings us to the dominant follicle. So this dominant follicle is the one that's going to release the egg right before your menstrual cycle, okay? So antral follicles are recruited to begin. And again, GnRH is the one that was released FSH and LH to go to the ovaries to tell those follicles, hey, develop, and one of you is going to become the dominant follicle, and then you're going to release an oocyte, okay? Now, these follicles by selection, they're reduced. And again, how are they reduced? I said this earlier, and Maha mentioned it. Can anybody tell us? What determines the dominance of a follicle? Good. So Amani said it in the chat. Because of the number of receptors, specifically FSH receptors. Good, Ibrahim and Ramin. Nice. Okay. So the number of FSH receptors is going to determine the dominance of the follicle. Okay. Now keep in mind, it remains in meiotic arrest, right? The only time it will go back to undergoing full meiosis is if the egg, once it is released, is fertilized. However, that is not the case in menstruation. Sorry. So the dominant follicle now responds the most to FSH, and then it grows into the largest form. And then at the same time, because so much estrogen is being released, that is now causing a positive feedback loop with the pituitary, telling it to release more LH. And then now fecal cells start to express LH receptors and then produce androgens at the same time. And that's important because you're going to be using these androgens for estrogen and progesterone production later, right? This over here is just going into detail, telling you exactly what's happening. So aromatase is the enzyme that is responsible for androstenedione and estrogen production, right? Androstenedione is made and then it is converted to estrogen or estrone. Okay, estrone is a weak form of estrogen. You have both. And then the FSH then, again, binding to the FSH receptors, estrogen is being produced, and that estrogen is telling the pituitary to release more LH that binds to receptors on the fecal cells, okay? So over here, you'll quickly see the time scale of folliculogenesis. So over here, you notice like I told you guys before, irrespective of the cycles, folliculogenesis is occurring and they're maturing at different stages, right? So you have your preantral follicle that comes from your primordial follicle. It takes 25 days for it to become an antral follicle. So this is your first cycle, okay? So typically, for example, if you guys remember, this is more for, I guess, like the females. The first few menstrual cycles are not very regular. The bleeding is not, and you guys also learned about this. The bleeding in the first few cycles is not the same. Typically, it's lighter. Sometimes it's heavier. It's irregular. Sometimes they're going to happen 2 months apart, sometimes 3 months apart, sometimes weeks apart. That is because of your pulsatile GnRH release, and also because full folliculogenesis has not been occurring enough for it to release a proper oocyte. So you're going to have a few anovulatory cycles the first few times. Anovulatory basically means you're not having ovulation. You're still having a cycle, but you're not having ovulation. Okay? So over here in the first few cycles, you'll see that. Now, once you get to like the third, fourth cycle, you're going to see that you're going to start to have a dominant follicle. And then every time from then on, you're going to have a dominant follicle that is ready because it was resting in a different stage from before. And then it releases an oocyte. And again, this is all gonadotropin dependent. So GnRH is released again from the hypothalamus, goes to the pituitary. FSH and LH is released. are released. They go to the ovary. FSH is causing folliculogenesis. Estrogen is being released. Estrogen in the first 10 days is telling the pituitary, don't release so much LH, we don't need it. After 10 days, high concentration of estrogen going to the pituitary saying, never mind, bring that LH back, we need it now, because we want the dominant follicle to burst. Okay? This is another way to show you what I just showed you over here. This is all from Dr. Abdul Jabbar's lecture. So it's basically this graph in different words, okay? Now, this is to go into more detail. Usually, you will not be asked about every single one of these details from this lecture, but if you guys, just tell me quickly, you guys got a mole lecture, right, on steroidogenesis and everything?
Yes.
Good, okay. So you guys are going to be tested on it from that, okay? You're not going to be tested on it from here. What they want you to know from this lecture is basically that you understand FSH and LH release, its relation to the ovary, what's happening in the ovary. So folliculogenesis, dominant follicle formation, FSH receptors, it bursting, releasing an oocyte. Bursting is not the right word. Say rupturing. If you guys get an SAQ, say the word rupturing. Don't say bursting. It's technically not correct. So dominant follicle rupturing, releasing the oocyte into the fallopian tube and the corpus luteum, and what's happening. This is all very specific, going into basically what exactly is happening in the cell in terms of steroidogenesis. Refer to your mole lecture for this because it is more clear and it has more detail. This is just to tell you that, hey, look, this is happening in the follicular cells, okay? You have your basal lamina, so you have your follicular cells and you have your thecal cells. So what cell is this? Oh, it says it right here. Okay, this is your thecal cell. Good. Thanks, guys. So I wanted to see if you guys understood that because there's LH, there's an LH receptor right here. So remember that your thecal cells have the LH receptors, your granulosa cells have the FSH receptors. So the FSH receptor cells, granulosa cells, are what are forming the estradiol or the estrogen. Your thecal cells are what are producing your testosterone, androstenedione. Remember that even in females, you need a certain amount of testosterone because it does balance out with your estrogen. However, you do have more estrogen. They're both responsible for your secondary sexual characteristics, okay? And androstenedione, this is important because this is an androgen. It can go and then now it can be used in your body however it needs to be used for secondary sexual characteristics. And it goes to the granulosa cells to be converted into estrone, okay? So this is important because now, after folliculogenesis is complete, after your dominant follicle ruptures and everything, when you have the oocyte gone, your corpus luteum starts to form. However, you still have estrogen production, but you don't have a follicle anymore. So how is it happening? Via this. Androstenedione is being produced by the thecal cells and is also being produced by the corpus luteum. And in that androstenedione, again, can be used to create estradiol. It's obviously not creating as much because these enzymes are going to be downregulated once folliculogenesis is complete, okay? Because of feedback inhibition of inhibin, which we're going to talk about in a second, okay? So again, the dominant follicle is rupturing and the cumulus oocyte complex, again, the corona radiata around the oocyte, it's being released because these are important because it also helps in the selection of sperm, right? Into which one is going to fertilize the oocyte if there is sperm present. And then your ruptured antrum and everything, so everything is released. So what is happening is then the fecal cells are luteinizing. Now what this means is they are now focusing on specific steroidogenesis, specifically progesterone production, inhibin production, and very little bit of estrogen via what we just said. Androstenedione in the luteinizing fecal cells can be used to make estrogen, okay? There's different ways of making estrogen. It's not only in your granulosa cells in the body. Remember that your adrenal cortex is also responsible for making estrogen. And although a majority of it does happen in the ovary during the follicular phase, okay? So again, hormonal regulation. Let's go over this one more time. This is what he wants you to know from the lecture. GnRH goes down the stalk from the hypothalamus to the pituitary, goes to your anterior pituitary, and it tells the anterior pituitary to release FSH and LH, which are both going to your ovary and they're acting on different cells. FSH is going to which cells? the granulosa cells around the oocyte, okay? It's going to form an antrum, which is a fluid-filled cavity that contains the nutrients and everything that is necessary for the growth of the corona radiata and the granulosa cell layers, etc. Okay? Your LH is going to your thecal cells, and that is more responsible for androgen production, which go to your granulosa cells that become estrogen and inhibin. Okay? These go back to your pituitary. So the estrogen will go back in the first 10 days and say, hey, stop releasing LH. We don't need it. After 10 days, at a higher concentration of estrogen, it's going to say, never mind, release the LH. Okay? Because now the receptors in your pituitary are reacting differently depending on the concentration of estrogen. So low estrogen, don't release LH. Because what does LH mean? It means that the dominant follicle is ready to release the oocyte. But we're not there yet. We're in this stage, right? Let's quickly go back to that very, very beginning. This one. When you're in this stage, are you ready to release the oocyte? No, right? So you don't want LH to be there, because if LH is there, it'll start to luteinize the thecal cells, which means that you're going to be starting this process. But if that happens, then that means that the oocyte had to already have been released, but that was not the case. So estrogen production in low concentration is going to tell LH, we're not ready for you yet. In high concentrations, that means that you're here. So in high concentration, it's going to say LH, come back, because this is what LH is going to cause, ovulation. Okay. Amina Farheen, you raised your hand. Yes, please ask.
Yeah, I have a question. So does that mean that estrogen is involved in the formation of the antrum?
Is estrogen involved in the formation? Not directly. So FSH is involved in the formation of the antrum, right? So the FSH receptors on the granulosa cell. So FSH is binding, granulosa cells are doing their thing, antrum is forming. Estrogen is basically the product of the FSH acting on the granulosa cells. So the estrogen itself is not causing the antrum to be created. The estrogen is going back to the pituitary to tell it what to do. Does that make sense?
Yeah, thank you so much.
No problem. Okay. So the first 10 days, estrogen exerts a negative feedback on the hypothalamus, on the pituitary, not the hypothalamus. Okay. It's someone 221606. Someone asked me, this is a direct message in the chat. So they said the first 10 days, estrogen exerts a negative feedback on the hypothalamus and then switches to positive feedback, causing more LH to be released, right? Correct, except not the hypothalamus. Remember, hypothalamus releases GnRH, not FSH and LH. FSH and LH is released by the pituitary. So the GnRH is going from the hypothalamus, like we showed over here. So the hypothalamus is releasing the GnRH, which is going to the pituitary, which is releasing LH and FSH. The estrogen is going back to the pituitary. In the first 10 days, you're right. Negative feedback. We don't want LH. And then now after 10 days pass, when it's a higher concentration of estrogen, then it's going to say, yes, LH, come back, because now the dominant follicle is ready and we need to ovulate. It's not literally saying that stuff, but obviously through chemical reactions, it's saying that, okay? Now, Amina, the function of inhibin, I'm going to get into that in a second. Ramin, can you repeat why the antrum is formed? Yeah, sure. So the antrum is formed, it's a fluid-filled cavity. That fluid is over there because it's carrying nutrients and everything for the granulosa cells to use in order for it to grow. That's basically it. The antrum is just forming as a byproduct of like the FSH coming, binding to the receptors on the granulosa cells, and it's creating all these hormones. And obviously, you know, if you're going through steroidogenesis, you need a lot of amino acids, you need glycoproteins, you need steroid precursors and everything. So the antrum also holds that stuff. Okay? Is that clear? Dominant follicle. Awesome. Okay. So let's see over here to make sure. Okay. You guys understood the slide? I'm not going to go into this detail because this is done in your mole lecture. It's a completely different lecture. I'm just going to tell you what the main things are. So LH goes to thecal cells, FSH goes to granulosa cells. Granulosa cells make the estrogen. Thecal cells make the androstenedione or the androgens. Androgens are used in the body for certain functions, and the rest will go to granulosa cells to create more estrogen, okay? Okay, Tasneem, how do estrogen levels determine FSH and LH release? So the estrogen, again, okay, let's go back to, I'm going to try and find I put this image towards the end, but I feel like I want to show it to you guys now. Okay, where did it go? Damn, I cannot find it. Okay, just give me 1 second. I'm gonna find you guys a different picture on Google. That will hopefully, there you go. Okay, so I'm gonna screenshot this and open it. Just give me 1 second, guys. I'm gonna show you something and I hope this is gonna make everything clearer. This is the best image I can find. This shows you the menstrual cycle and everything at the same time. And hopefully this will answer your question. Can you guys see the image? Okay, so to answer your question. Yeah, Tasneem. Okay, to answer your question. How does the estrogen determine FSH and LH? Okay, so like I showed you guys earlier in the picture of the ovary, and then before that, LH and FSH first is released. Okay, so GnRH from the hypothalamus is released in a pulsatile fashion. So it's like coming like this. Okay, at different times of the month. It's going to the pituitary because you don't want to have GnRH there all the time, right? You want the pituitary to be able to respond to it. So if you want something to respond, you don't want to give it too much of it, okay? So GnRH, all of a sudden, at the beginning of your menstrual cycle, so over here, at this time, day 0 of the month, let's just say that you get your period on the 28th day, the 28th day of the month, on day 0, so the first day of the month, GnRH is going to the pituitary. It's saying, hey, release FSH and LH. FSH and LH are going to the ovary, okay? And in the ovary, in your primary follicle, in your preantral follicle, you have a layer of granulosa cells. They become cuboidal in response, okay? When they become cuboidal, they start to actually, cuboidal, do you guys remember in first year when Dr. Annie would talk about how the structure of the cell directly relates to its function? So like a squamous cell obviously is not producing a lot of stuff because it's tiny. So how can it even be producing anything? Cuboidal and columnar cells are obviously, they have a lot of functions. So when something becomes cuboidal, that means it's starting to do something. So in this case, those granulosa cells are starting to produce estrogen. And you need a lot of space when you're making steroids, okay? Because you need amino acids, glycoproteins, steroid precursors, blah, 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 blah. All of that stuff to be coming in and making estrogen. So your FSH receptors bind to the granulosa cells. They're going to start producing estrogen. It's telling your granulosa cells, hey, produce estrogen. We need estrogen because we need this estrogen to rise because we need it to tell the pituitary to not release LH yet and then tell it to later produce LH and come, okay? Your estrogen is also responsible for your secondary sexual characteristics. So in females, that is the appearance of your genitalia, breasts, blah, blah, blah. Testosterone is responsible for hair growth. And in men, testosterone is like basically what estrogen is for us, testosterone is for males, right? That is what in the appearance of your genitalia and your other secondary sexual characteristics, deep voice, facial hair growth, etc. Okay? So that is why the estrogen is then released. Now, how do estrogen levels, now to answer your question, determine FSH and LH? Well, estrogen is not going back to tell anything for FSH, but the estrogen is going back to say, hey, don't release LH yet. Continue to release FSH because we're still creating our follicle. So while this is happening, folliculogenesis, FSH is like slowly, it's like already rising and then it kind of stays at a continuous level, consistent. Do you see that over here? Consistent. Your LH is low. It started to rise, but then it stopped and it kind of went down and down and down and down. And what are you noticing at the same time? The estrogen was slowly rising. What is happening while the estrogen is rising? Your follicles are becoming bigger because your granulosa cells are more, because you're producing more estrogen, okay? So more estrogen production in the first 10 days. It's rising. It's going back to your pituitary. It's saying, don't release this LH yet. That's all it's saying. That's all you need to know, okay? Then when it rises after day 10, do you see over here? After day 10, that rise in estrogen is telling the LH now to be released by the pituitary. And that is why you have this big LH surge, okay? And what's happening once you have your LH surge? You had ovulation. LH surge caused ovulation to occur. Then your LH will rapidly drop again. And what's happening when this happens? Your granulosa cells stop producing estrogen. So that also reduces. Okay? Is that clear? Or do you guys want me to re-explain anything in this phase, basically, in the follicular phase? Do you guys? Awesome. Okay. Sorry. So now someone asked the sorry guys, every time I cough I feel like I lose my train of thought. Someone was asking the importance of inhibin, the function of inhibin. Inhibin basically will go back. It's not, is it here in this chart? No, but there was one where it was. Inhibin will basically go back and tell the pituitary to stop releasing FSH-LH, more specifically FSH. That's basically what's happening. And that's why you'll see usually inhibin will rise over here. I don't know where it is in this graph. I'm going to try and look for one with it. But inhibin will rise over here because, again, when you're in this phase, you don't want folliculogenesis to be occurring, right? So inhibin is going to be going back to the pituitary and telling you like, hey, don't release FSH because right now we want progesterone to be released because we want a thick endometrium. So I'll go into that now. I'm going to go back into the lecture and we'll continue to talk about that. And then we will be done and I will be ready for your guys' questions. Just give me 1 second. All right. Okay, so we talked about the dominant follicle. And is this clear to you guys? So ruptured follicle, oocyte is gone. And now you have all these granulosa cells they're going to stop producing as much estrogen because they don't have any reason to, because your FSH is going to start to fall, right? Because your luteinizing thecal cells are now doing their thing, right? What they're doing is they're producing progesterone, a little bit of estrogen and inhibin. Estrogen is going to be produced. And now your progesterone is also telling your hypothalamus, we don't need any GnRH. Like, no, thank you. We don't need any more because we don't need more FSH and LH. We're already done with the follicular phase. And then the inhibin is going to go back and say, we don't need FSH. Why? Because we are not in the follicular phase anymore. We are in the luteal phase. This is the luteal phase, okay? The production of the corpus luteum. The corpus luteum is basically your thecal cells, and they look yellow here. And even if you look at gross pathology, guys, like a gross image, or if you look at it under a microscope or anything, when you stain it, you know, when you look at something that is more predominantly lipids or steroids, you notice how it like shows up light, like it shows up as fat. That's basically what it looks like because it's just doing steroid synthesis. That's literally all it's doing. It's making progesterone, a little bit of estrogen, and inhibin, okay? And the inhibin is going back saying we don't need FSH because we're not in the follicular phase. The progesterone is going up. It's saying we don't need GnRH because we don't need FSH and LH. We're not in that stage anymore. The LH did its job, FSH did its job, and the estrogen is being produced as well throughout that time because it has its other functions, right? Secondary sexual characteristics, etc., blah, blah, blah. However, you guys will remember from that picture I just showed you, like this one right here. Sorry, guys. Here you go. You'll notice that the estrogen over here is not as high as it was in the follicular phase, right? That is because we don't need it to be doing what it normally does in terms of feedback inhibition with the pituitary. Over here, the job of estrogen is different. Over here, it was multiple things, right? Go back to the pituitary, tell it we don't need LH. Then after 10 days, tell it we do need LH. Now over here, any estrogen that's being produced is there as a function for the rest of the body. It's not really there for the pituitary. That's why it's not as high, okay? Is that clear? All right, okay. So now I'm going to talk about the ovarian hormones. I know that Dr. Abdul-Jabbar talked about these things before he talked about folliculogenesis. You guys can tell me what you prefer, like give me that feedback. I feel personally it's easier to talk about these things more in detail when you kind of understand like what's happening and then now you know their function, right? So estrogen is done enzymatically, again, by aromatase and other things in the granulosa cells and the theca cells, because the theca cells are making androstenedione, which is then going to the granulosa cells, which is turning it into estradiol, estrone, and estrogen, right? 95% of it, again, is made by the ovaries. A small amount is converted by your adipose tissue, that's estrone, estradiol, and then some of it is made by your adrenal cortex, okay? Oops. And you have your androgens. So again, your ovaries are making your androgens as well as your adrenal cortex. That's all you have to know from this slide. Okay? Now, the progesterone that comes out in the luteal phase, that is responsible for steroidogenesis to produce progesterone. And why is that progesterone important? Because it maintains your endometrium. In case your egg, in case your oocyte is fertilized, it will implant into the endometrium. Okay? When that doesn't happen, after a certain amount of time, your corpus luteum will start to like go through not atresia, what's the correct word? It'll just stop developing further. It'll start becoming apoptotic. It'll start to die out, right? That means that there's a fall in progesterone, and that is what results in a menstrual period. Basically, the shedding of the endometrium, because you no longer have the progesterone to support that endometrial lining, okay? Now, the inhibin is produced by the granulosa cells, and it's also produced later by the luteinized theca cells. It basically regulates, goes back and regulates like FSH and LH, and it has, so it's regulated by FSH and LH, later goes back when it's coming from the luteinized theca cells to tell FSH and LH to not be released anymore. And it's also regulated by other growth factors, okay? And an inhibin B is also a marker of granulosa cell function. And inhibin A is a marker of corpus luteum function. So you'll notice that you have inhibin in both, right? They are slightly different in terms of their structure, meaning like you have an A and a B. And basically what happens is inhibin A is the one that is being released by your corpus luteum, which is going back to your pituitary, telling FSH and LH not to be released. Inhibin B is going back, and it's basically inhibin from its name, inhibin, it inhibits. It's going back, it's not inhibiting FSH entirely, but it's to regulate how much is released by the pituitary. Like you guys will see in that graph even, the FSH is not like going crazy high up and down. That's because it's highly regulated, okay? Activin is another hormone. It's produced by the granulosa cells. It has a paracrine function on the granulosa cells. It basically promotes granulosa cell proliferation. So it's a locally acting hormone. So you notice some hormones go into the blood to circulate around the body. So estrogen, progesterone, blah, blah, blah. Activin is basically something that is a locally acting hormone, okay? Now, it also goes into the blood, into the blood vessels. It goes back to the pituitary, and it is an antagonist to inhibin. So it stimulates pituitary FSH, because again, what's happening? Activin wants the granulosa cells to be doing their thing, and the granulosa cells do their thing when they have FSH present, because they are FSH dependent, right? So activin and FSH go hand in hand. Inhibin will stop FSH. Just remember it that way. Inhibin inhibits, activin activates, okay? That's all you need to know. Now, we went over this already. Do you guys understand the LH surge? Or better yet, does anybody want to explain basically what's happening? Somebody tell me, okay, somebody answer me this. How does the LH surge occur, and what is happening, and why is it important? Does anybody want to answer?
I can try and answer this.
Yeah, sure. Go ahead.
So basically, the high estrogen, like at the beginning, it's an inhibitory effect on the LH levels, but then during like around the 14th day, it starts to be a stimulatory effect, and then it will trigger a surge in LH, which will allow the cell to basically go through meiosis 2, and this is by I think it was allowing the phosphodiesterase, which was inhibited by increased CGMP, and then it basically stops the regulation that CAMP has and allows the cyclins and the I don't remember the other one, but the cyclins to basically go through and like complete meiosis 1 up to meiosis 2 of meiosis 2.
Okay, that was pretty close. So good job. The only thing I will correct is it's not the 14th day, it's the 10th day. And the other thing the other thing I wanted to add is yes, it basically puts it in meiotic arrest. And all you need to know about cyclin D1 and CDK, all that jazz, is they're just involved in the cell cycle. That's all you really, really need to know. They form that complex, and then that's basically what's involved in the meiotic arrest. That's all you need to know. But good, you were able to go into detail, so good job, okay? Now, the LH surge, like our colleague mentioned over here, firstly, it has estrogen was telling the pituitary not to release LH in the first 10 days. In the next 10 days, yes, release LH. A huge surge happens, then ovulation occurs. So the rupturing of the dominant follicle, right? Now that dominant follicle released its oocyte. So ovulation is the process of the rupture and release of the dominant follicle from the ovary into the fallopian tube, like we mentioned multiple times earlier. That is where it will maybe get fertilized if sperm is present. If sperm is not present or not yet present, let's just say, that's why the corpus luteum develops once the ruptured follicle, once the follicle ruptures, because progesterone is being produced to preserve the endometrium, okay? Now the endometrium is then preserved, and then once the 28th day of the full menstrual cycle comes and there's no sperm present and therefore no fertilization, you're not going to have anything basically to implant into the endometrium. And then the dying corpus luteum will stop making so much progesterone. Okay. Now for that LH surge, again, it induces the oocyte to progress into metaphase 2. That is because it's expecting to meet the sperm and complete its entire process and do the cell division, but it doesn't. Okay? So it closes the gap junctions between the cumulus cells, decreasing cyclic GMP, and as our colleague mentioned, so this allows phosphodiesterase to degrade cyclic AMP. Why? You don't want more steroidogenesis to be happening in that area. You don't need more estrogen. You don't need anything else, okay? The progesterone is now going to be made by the corpus luteum. So a decrease in cyclic AMP and protein kinase A activity. Protein kinase A, so okay, you guys will probably remember this from mole and everything, but please, 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 for your guys' own sake, don't overcomplicate this for yourself. Okay, there's no need to. You don't need to know every single thing about protein kinase A and cyclic AMP, GMP in these physiology lectures. It's more important when it comes to your mole lectures, okay? It's basically here to tell you, in simpler words, the decrease in the activity of steroidogenesis and in the activity of other cell division processes. That's all it's meant to tell you. These are very specific. These are just specific proteins and enzymes and kinases, right? So specific enzymes that are working in those processes. But all it's basically telling you is steroidogenesis and cell division right now is stopped because we don't need it right now. The steroidogenesis, any of that that's happening is now still in the ovary, not with the corona radiata, not with the cumulus oophrys, not with those cells. Okay, whatever is released in the fallopian tube is now in arrest. It's waiting for the sperm to continue that process, basically to go back into the cell cycle and cell division process, okay? MAPK is basically what was stopping any further cell division. So when fertilization occurs, MAPK will be degraded and then you will complete meiosis. This is more on the endocrine function of the LH surge. If you guys want to go into it to understand this more yourself, I explained it in a reviewed fashion. But if you guys want to understand specifically what is happening in the cell in terms of the G protein coupled receptors, cyclic AMP, protein kinase A, etc., it's all over here, okay? So the LH will basically inhibit cyclic GMP, and that will inhibit this PDE3 over here, PDE3A. And what happens? Can you guys tell me? Okay, that's okay. An LH surge basically just means, yeah, sure, I can repeat the question. So I said over here that the LH surge is inhibiting cyclic GMP, right? Which normally will go in and inhibit PDE3A. So what does that mean over here? If you know that cyclic AMP, like let's just say steroidogenesis, cell division, all of that requires cyclic AMP, what does that tell you? If LH is present and it's inhibiting cyclic GMP from going in, which normally inhibits PDE3A, which normally acts on this. It's a lot of steps. I know it's a bit confusing, but it's just a matter of understanding. It basically means meiotic resumption. Okay, it's right here, right? So LH surge basically means oocyte is released. That means maybe there's going to be fertilization and we're going to resume meiosis, right? Then it goes back into meiotic arrest. And then once it meets the sperm, then it's supposed to continue its whatever it continues, right? It's supposed to continue division of cells and that will become an embryo, etc. Otherwise, it stays in meiotic arrest, okay? So the LH surge causes meiotic resumption. That's why it's important over here. This is basically just to explain to you what's happening in a cell. This is explained by this one line here. Just know, forget about all of this in the middle. Just know, LH surge, meiotic resumption. That's all you need to know. Meiosis is reoccurring, like it's coming out of arrest, okay? This is a quick table that the doctor included for you guys to see if you guys want to understand it more in terms of the timing, everything. So what is present and what is not present at certain times. But we went through all of this in the review. And we already talked about this. So the corpus luteum, again, it is it is basically producing progesterone, inhibin, and estrogen. The progesterone is important for the endometrial lining to be maintained. The estrogen is there for secondary sexual characteristics, and the inhibin is going back to the pituitary, which suppresses FSH secretion because you don't want folliculogenesis when you're in your luteal phase. Okay? It turns eventually into the corpus albicans. Albicans is basically, alba is white in Latin, basically just means white body. It's a little tiny scar. That means it stopped its function entirely. It's just scar tissue. And that is basically it. Okay. Now, again, this is another picture, I think, of the thecal cells and granulosa cells and the LH receptors on the theca cells. It's already what I showed you guys earlier. So androstenedione is released into the blood vessels. It also goes to the granulosa cells and it can become estradiol. Okay. And then a quick fun fact before, and I have a few questions for you guys from academic aid. We're going to do them together so that we can ask each other questions in case you guys have any confusion about anything. Middle schmears, known as middle hurts. Sometimes some females can feel when they ovulate, and that's an interesting thing. It's called middle schmears. So basically, if any of you feel like a random pain in the middle of your menstrual cycle, sometimes that can mean ovulation. And that's basically just peritoneal irritation. So remember that your peritoneum folds over around your ovaries. And when your ovary is releasing an egg, sometimes there's some irritation because of follicular swelling, rupture, fallopian tube contraction because it's getting the oocyte to it and everything. It can kind of feel like appendicitis. So if you ever feel like a right lower quadrant pain, it can be on either side. But if you ever feel that type of pain, it's like a sudden pain and it like lasts for a little bit and then it goes, it's usually that. Okay? Now, you guys know this, and you know, you might know this from other females, women in your life and anything. There's a lot of things that can affect your menstrual cycle. So heavy exercise, people who are athletes who train many, many times, they can sometimes suppress their hypothalamic function. So those people sometimes, and you'll see this especially like in athletes who compete in the Olympics, they will typically hit puberty much later than the regular person because their hypothalamic-pituitary, that entire circuit is suppressed because of heavy exercise. Okay, so heavy exercise, starvation, high prolactin, that you guys will have learned about this probably from your lecturers. For example, in women who are lactating after they give birth, you don't want to be having a period immediately, right? Because you want your body to be making more prolactin and everything. You don't want your body to be getting ready to become pregnant all of a sudden. Your prolactin is going to inhibit FSH and LH secretion because it's inhibiting GnRH secretion. Okay? All of these things affect your hypothalamic and pituitary circuit. Do you guys have any questions specifically about this? All right, awesome, perfect. If you guys, seriously, please, if you guys have any questions, please feel free to ask, okay? Now, thank you. You know where to find me. You can text me, but you know where to find Dr. Abdul Jabbar if you ever have a question for him. He's next to the ATM. When I personally looked at his slides right before, like, you know, when I was preparing to teach you guys, I myself also think he obviously likes to include a lot of things on his slides. He's been like this since I was in first year, fifth year now, in a while. But I hope that that made it a little bit easier. I was gonna make my own slides for you guys, but I got really sick the past few days. I actually have tracheitis. I think I said that in the beginning. So I was coughing all day today. So I was like, you know what? I'm just going to use his slides, but I'm going to kind of redo them. So I have a few questions for you guys to practice with. Allah yasalmak. And we're gonna do them right now. Okay, so here, first one, and they're not hard questions. Hopefully, inshallah, but we'll discuss them together, okay? So, the source of the increase in the concentration of, actually, no, someone else read the question because I want to make sure you guys are still here. Who wants to read the question and the options and answer it? I don't want to call on you guys. I want you guys to do it yourself. All right, okay. So you guys are answering already in the chat. I'll read it out loud. Okay, so the source of the increase in concentration at point D, over here. Can somebody first tell me before we answer, like you guys already, obviously you know the answer, but what is this hormone over here? Like, what is this line?
Estrogen.
Good. Good, it's estrogen. What is the black? Progesterone, good. What is A? Not A, sorry. Yeah, okay, what is A? Like, what is the green line? This is the one that was missing from the diagram earlier. Good, yes, good job, Payam. It's inhibin. It's typically lower than the rest, okay? So inhibin, progesterone, estrogen, and then we know that these ones are FSH, and this one is LH, because remember, LH has a huge surge, okay? And you can even see with the estrogen, right? More estrogen, high LH surge, and then they both decrease, and then estrogen is slowly just about by the corpus luteum, which is the answer. Good job, guys, because you answered in the chat. It's C, corpus luteum. Very good. Do you guys understand this, or do you want to discuss the other options? I'm going to take that as you guys understand this. Next question. The cause of the sudden increase shown in point E over here is A, negative feedback of progesterone on the hypothalamus, negative feedback of estrogen on the anterior pituitary, negative feedback of FSH on the ovary, positive feedback of FSH on the ovary, or positive feedback of estrogen on the anterior pituitary. Okay, 6. Good job, guys. It's E. Very good. So remember, like we discussed, high estrogen levels after the 10th day onwards now has an activating effect. No longer inhibitory, now activating. So it starts as negative feedback loop over here in the first 10 days. After that, in the next 10 to 14 days, it is a positive feedback loop. So it's activating. Very good. So positive feedback of estrogen, that will cause the LH surge over here that you see. Very good. Now, a healthy 31-year-old woman comes to the physician because she is trying to conceive. She is currently timing the frequency of intercourse with at-home ovulation test kits. An increase in the levels of which of the following is the best indicator that ovulation has occurred? Keywords is has occurred. Okay, I see a few of you saying D. Great job, guys. So it is D. Tasneem, where is inhibin coming from in the first half of the graph? The granulosa cells are making inhibin. So it's being created with the other steroids. Yes, exactly. Good job, Tasneem. So it is the reason that FSH doesn't rise as much as LH. So it has like an effect of basically just kind of controlling how much is released, right? You want your FSH to be there. You want it to be the main thing working, but you don't want so much of it that you have like 10 follicles forming at the same time. You know what I mean? Because you do want to have one dominant follicle at the end. Now, you guys are not going to learn this now. Wait, let me see. Is there, okay, last question. I'm going to tell you what I was about to tell you. What accompanies, so you guys were right about this. Ovulation has occurred, progesterone is high, because that means that ovulation has occurred, so now you're in your luteal phase. Luteal phase means you're making progesterone, okay? Now, last question. What accompanies sloughing, sorry, some people say sloughing of the endometrium during the endometrial cycle in a normal woman? A, increase in progesterone, B, LH surge, C, decrease in both progesterone and estrogen, or D, an increase in estradiol. Good job, guys. Perfect. It's C. So sloughing of the endometrium means that there's a drop in everything else, especially progesterone. So decrease in progesterone and estrogen. Now, that is the end. You guys can scan this code and it will take you somewhere. I actually didn't check where it'll take you, but if you guys want to check it out, you can check it out. Now, I wanted to tell you guys really quickly about a few things. Number one, if you want a really good video to watch on the ovarian and menstrual cycle in general, there's a video by Armando Hasidungan. I'm going to share it with you guys right now in chat. Give me 1 second. I will literally just copy paste that link and you guys can save it for yourselves. It is a phenomenal video. So that's the video. I sent it in the chat if you guys want to share it with your colleagues and everything. And the next thing that I wanted to say is there's a different video also by him on the steroidogenesis and everything. If you guys want to learn more about that, if you're confused, I highly recommend watching it on YouTube by the same guy. He's very, very clear and he draws it out in front of you. So if you're a visual learner, he's great. And then last thing I want to share with you guys is when you get to 4th year and you do OB-GYN for your rotation, you're definitely going to, everybody has to do OB-GYN. You're actually going to be going to the fertility clinic and you're going to be seeing this. So typically right now, it's just like in case if you guys are interested before you guys leave. Sorry, we're going over time a little bit. A lot of couples are trying to conceive, right? So they go to the doctor, they're like, hey, we haven't been able to conceive in like a year. What's wrong? So they'll usually get like hormone therapy. And these women will be getting FSH and LH shots, right? And other shots in terms of like, for example, estrogen, progesterone, usually it's FSH and LH. And they're taking certain shots at a certain time in their cycle to time it with their menstrual cycle, just like what I showed you. This is so that they can have more follicles be produced at once. So they're taking FSH and then sometimes these women will feel a little bit of pain because they have a lot of follicles at the same time, right? A lot of follicles forming because these oocytes are then extracted and then, IVF, in vitro fertilization, you take a bunch of follicles. So basically when you get to that time, kind of remember this physiology and you're going to remember why, okay? So FSH, folliculogenesis, so you're going to have a lot. And that's why you don't want it in all points of your cycle. Just like a little piece of information in case that was interesting. But yeah, do you guys have any questions for me? Anytime. Thank you guys so much. Genuinely, please, if you have any specific questions or anything, feel free to text me. I am going to put my number in the chat. This is my number, and this is my email. Please feel free to email me, text me on WhatsApp, send me a voice note, whatever you want at any time. And best of luck, you guys. You got this. Please, please, please just do practice questions. It's the most important thing, okay? And you will be ready for your exam. Do Guyton. If you guys can find UWorld Physiology, yes, the questions are long. They can be a bit intimidating, but I promise you they will give you the best practice you could possibly get. And do AMBOSS Physiology questions, okay? And please, 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 also, last thing, if you guys have any feedback for me, please tell me what I can do better next time, if I can explain anything differently, and anything else. Text it to me. Don't feel shy. I'm not going to yell at you. I'm not going to bite, okay? Best of luck, guys, and happy studying. Please take a break, eat dinner, and have fun. Bye.
Thank you so much, Dr. Bye. Get well soon.
Thank you.